Sound check, check. check one two. Hey 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 hey. Sound check check one two. Sound check 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 check. Check one two. Hey hey hey. Sound check check one two. Hey hey hey. Sound check 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 one two. Sound check hey 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 hey. Sound check check one two. Hey sound check check. Mic test one two. Hey hey hey. Sound check.
Tapi sama Nagsasalita na ako, doktor, at tinitingnan ko. Checking audio ko.
Ma'am, huwag kayo mag-open ng microphone.
Tama na. Hindi ba nagsistart? Anong ano mo? Walang ano si PD? Ready to register? Iinarot. Iinarot. Inaalalayan lang namin niya parang naman.
biyaya.
The YouTube Music app has mixes made. Every movie, seriously, every single one. Get YouTube Music Premium.
Sa meeting ko. Ay, ito ba na yung 7? Oo. Yun ang kinain ko. Ako, kinala niya na tayo. Isa yung nilaisin sa andun na yun. Yung tinilaga sa aso.
Pwede.
Hindi naman po qualified kayo. Nagawa mo sa chart? O, din. Gagawin po ang legit na. Tapos no, ano naman po. Transfer order lang po. Wala pa siya doon. Schedule. Hindi na ako ID ka na yun. Ano ba? Hindi po siya talaga umiinom. Ano sabihin mo? Regular dialysis.
Text mo na lang sa akin kung magkano. Tapos may kasama pa ako sa
Makakatingin ako sa camera. Ito, ang taas. Ay, tataas pa ba yung silo niya?
Dok, tingnan mo ikaw kasi nakikita.
Yan nga eh.
Kung okay na siya pag umupo.
Alisin mo.
Alam mo ikaw.
Kasi nakatingin ako sa baba. Hindi ba pwede nakatingin ako sa taas?
Hindi na siya oral, kundi i-inject na sa kanya para mabilisan kasi emergency na yung situation ng bata. Pero nag-refuse po
Good morning, everyone. Welcome to the very first Palliative Cardiovascular Care Symposium. And this is in cooperation with the anniversary celebration of the Philippine Heart Center. May I invite everybody to put ourselves in the presence of God as we open this symposium with a prayer. Together, let us
Dear
pray.
God, thank you for the opportunity to meet together. Please help us to come together to make this institution reflect your kingdom. Breathe life into our ideas and decisions. Help us build a team that has love and respect at its heart. Give us the strength to continue working for your kingdom in this time of pandemic. Lord, come give us the inspiration to be the best we can be. May we be a shining example of your goodness and truth within, wherever we are. Inspire our thoughts, discussions, and ideas, and continue to remind us that all that we do here today, all that we accomplish, is for the pursuit of truth for the greater glory of you. We ask these things in your name. Amen.
Let us now
Dear God,
welcome the
thank you
overall
for the opportunity
chairperson
to meet
for the
together.
48th
Please
PSA
help
Philippine
us to
Heart
come together.
Center Foundation Anniversary, our beloved Dr. Juliet Valderas.
Good morning, everyone, and thank you for taking time to attend this palliative care symposium of the Philippine Heart Center as part of the celebration of the 48th anniversary. The Philippine Heart Center's mission is really to provide comprehensive cardiovascular care enhanced by education and research that is accessible to all. At this point, as being the apex heart center in the country, we have reached a point at which we try to deliver more care, especially support for the failing heart. We now are embarking with left ventricular assisted device teams, and we have launched our heart transplant team, but it is not without taking care that we can do only as much, so that part of the care of these patients would be to create a comprehensive palliative cardiovascular care program that will take care of patients with complex heart disease, plus those even with simple heart disease, but with complications or with coexisting chronic illnesses. As a result, the Philippine Heart Center and the executive director of the Philippine Heart Center created the PHC Palliative Care Committee in February of 2021. This multidisciplinary committee is composed of several specialists with Dr. Florian Nuevo as the chair, nursing services, learning with the ETRS, and the hospital support services to address all the elements of a holistic health care plan for our patients. Thus, every patient who comes to the center should have a comprehensive care plan assessing both the physical and psychomotor health of each individual. In fact, as part of their accreditation Canada, which we underwent with a Diamond accreditation, it stresses that palliative care should be part of inpatient services, ambulatory care, perioperative, and rehab processes. So I would like to thank the Palliative Care Committee headed by Dr. Florian Nuevo for their tireless efforts in organizing not only the policy of the Philippine Heart Center in palliative care, but this very organization of this very important symposium. I hope that we can all learn something from this series of lectures which takes place today, and of course implement in the future for our patients in the next 5 to 10 years. Thank you very much, and congratulations, Dr. Nuevo.
Excuse us for a while. Can I have the next slide, sir? Naghang po dito. Thank you, Dr. Valderas. We're just so happy to see so many participants on the platform. So I hope in the next hour and a half or almost 2 hours, you'll be able to enjoy what we have in store. So this is simply unveiling. So hinuhubaran ho namin ngayon or ipinapakita kung ano ang magiging sistema ng programa. So let me just go through this. So as mentioned earlier, we were called to a first organizational meeting on a very special date. It's February 11. And February 11 is the World Sick Day. It's Our Lady of Lourdes Feast Day. And special because it's in the middle of the COVID. Yet a number of us heeded the call of our executive director, Dr. Joel Abanilla. And in 2 years or 1.5 years, we were able to give what is expected of us to produce a policy manual. And this manual is available on MedTrack. And we have a policy statement that we shall provide through this program in partnership with clients and families an interdisciplinary and multidisciplinary palliative cardiovascular care program whenever appropriate. And this is our mission statement. It's going to be a team approach of management, and education, training, and research shall be part of this to safeguard all the physical, mental, social, and spiritual aspects of life of our severely ill patients. And hopefully, we will be able to push with our vision, which is by year 2025, this program shall be embodied in the National Policy on Palliative Care and Hospice Care of the Philippines. And looking at that year, that is going to coincide with the 50th or Golden Philippine Heart Center Foundation anniversary. So it's a scary vision, but it's very inspiring. And I hope the rest of us will be joining together to realize this vision statement. So the program technically has three important objectives. First is to institutionalize an interdisciplinary program within the comprehensive patient care plan of Philippine Heart Center patients. And this is the first part for the operational plan for this objective. The second objective is to guarantee the enhancement of the program through the presence of responsive human, physical, and financial resources of our institution. And third is to develop and implement guidelines for an interdisciplinary team approach to palliative care with specific care plans appropriate to patients' needs. And that is what we're going to have this morning. So we are going to answer three questions. In the first session, the question is, why must Heart Center have this program? And to share with us the adult cardiology perspective is Dr. Yaneza, who is currently the head of the heart failure section. And from the pediatric cardiology division, we have Dr. Christine Gay Tria, who is a pediatric cardiac intensivist. And for the second part, we will answer the question, how can the program enhance patient care and overall client satisfaction? And in this part two, we have invited 5 other members of the committee. First is Dr. Maria Teresa Casiano, who will talk about the role of psychiatry in palliative care. Second, we have Dr. Marica Lumol, who will speak about neuropalliative care. Third, we have Dr. Edgardo Iba, who will speak about the role of cardiac rehabilitation in heart failure patients. Then we welcome Ms. Agnes Balid to speak about the role of the social worker. And last but not the least, on part two is Father Eliseo Navarro, our Heart Center chaplain. And the last part is very important to our institution being a teaching or training hospital. So how can the palliative cardiovascular care program enrich education, training, and research? And to share the relation of this or significance of this program on training and education is Dr. Ranulfo Havelosa Jr., who is the department manager for the Education and Training Department, and Dr. Consuelo Suarez, who is the co-chair for the Palliative Care Committee and currently the head of the Physical Medicine and Rehabilitation Department, but also a PhD holder in health research. After all the presentations, we will have an open forum, which will be moderated by our dear member, Dr. Maria Elena Bascot Yamson. She is an anesthesiologist and a specialist on pain management and palliative care. So my dear friends, please sit back, relax, and enjoy as we enter into our first session. And we all welcome Dr. Lilibet Yaneza, the head of the section of heart failure, a member of the committee, to give us the adult cardiology perspective. Thank you very much.
Patient shallow growth. Please proceed to seminar. Relatives of patients shallow growth. Please proceed to seminar.
Dr. Yaneza, can you hear us? We can see your slide.
Can you see my slides now?
Yes, please, you can go
Yeah.
on full slide view.
Yeah, I'm sorry, but I don't know how to do this.
On the lower part of the... Can you see that icon below with the 4 dots and then 2 icons to the right? Higher po, Doktor. Ayan.
Can you now see my slides?
Yes po.
Okay. Is it okay to proceed?
Yes, Doctora.
Hello, good morning to everyone. Sorry about that initial technical glitch. Good morning, Dr. Nuevo. Good morning, Dr. Valderas and the rest of the medical and allied staff. Hold on. Anyway, good morning again. So I am tasked here to give you a short lecture on why must PHC include a palliative cardiovascular care in its patient care portfolio. Hold on, just have to stop the barking of my dog. Okay, just to give you a short background on this disease condition that would gain much benefit from palliative care, and this is heart failure, and heart failure is considered chronic, progressive, and debilitating disease. In the Philippines, the prevalence of hospitalization for heart failure was around 1.6%. And despite advances in heart failure therapies, the survival rate is dismal. Nearly 40% of patients will die within a year of their first hospitalization, and an estimated 1 year freedom from hospitalization or death is only 33%. How do we define palliative care in heart failure? According to ACC 2022, this is defined as patient and family-centered care that optimizes health-related quality of life by anticipating, preventing, and treating suffering. And the palliative care should be integrated early into the care of all patients with heart failure. And also, ACC has espouses that these should be the following strategies that we should commence, and that would include high quality communication, estimation of prognosis, anticipatory guidance, addressing uncertainty, and down the line. What are the studies conducted regarding palliative care in heart failure?
We lost you, Doctora.
Hello?
Please proceed. Yes.
Yes, sorry about that. Regarding the studies on palliative care in heart failure, there was a meta-analysis that was published in 2018 that enrolled 5 patients, which gathered around 500 plus patients, and the study showed that palliative care intervention was found to significantly reduce the readmission rate and then the quality of life, but no influence on mortality. And then there's another study, which is a randomized controlled study known as the PALL-HF trial, or the palliative heart failure trial, that enrolled 150 patients, and they divided these patients into 2 groups: those who were given usual care and those given usual care plus palliative care. And they have used this following health-related quality of life tools: the KCCQ, or the Kansas City Cardiomyopathy Questionnaire, and the FACIT-PAL, or the Functional Assessment of Chronic Illness Therapy, a palliative care tool. And this study showed that the palliative care and usual heart failure management is associated with improved quality of life, although it did not affect 6-month hospitalization and mortality. I just want to briefly discuss this natural course of heart failure and to compare with other trajectories of decline, which can give us an explanation as to the reason why is it a challenge to institute palliative care in heart failure patients. And there are 3 main trajectories of decline at the end of life. And the uppermost would be represented by the red line. It is a trajectory with steady, predictable progression, and usually clear terminal phase. And this is typically noted in cancer patients. That is why palliative care is successful, since it is predictable and can anticipate needs for end-of-life care. The bottom line here is represented by the blue line. This is a trajectory with a prolonged gradual decline from an already low baseline of cognitive or physical functioning. This is typically seen in frail elderly patients or people with dementia. And then the middle line, the middle trajectory here is represented by your green dashed line. It is a trajectory with gradual decline, punctuated by episodes of decompensations and recovery known as dips and plateaus. And this is the trajectory noted in heart failure patients. Along this trajectory, this is sudden cardiac death could occur, particularly during exacerbation. Hence, palliative care is more challenging in cardiovascular care or heart failure due to its unpredictability. What do clinical guidelines say about palliative care or PC? In ESC, they have published this 2020 position paper on PC, and apparently they have been strongly advocating that PC should be early integrated into patients with heart failure. And this should complement an optimal guideline-directed therapy. And also in ESC 2021 heart failure guidelines, although they just focus on end-of-life care and advanced heart failure care, still they have advocated that palliative care should be part of the integral management for patients with heart failure. In AAC, this is the recent 2022 heart failure guidelines. They have again strongly advocated that that palliative care should be integrated into the care of all patients with heart failure. And they even strongly recommending that that PC should be given a role across all stages of heart failure, starting early in the course of illness, intensifying in end-stage disease, and extending into caregiver. So it's not only that we focus on the patient, but also on the caregiver. So just to expound further on these guidelines, starting with the ESC 2020 guidelines, on this table, they have divided the phases of heart failure into three: the chronic care, crisis care, and terminal care. And all these phases, they have recommended 4 steps on how to manage these patients using the palliative care approach. And these are assessment, discussion, planning near future, and advanced care planning. And just to expound further on this ESC 2020 position paper, they have listed down all these symptoms, and they have also stated what could be the comorbidities that we need to consider, and what tools that we could use to further assess them, and what could be the clinical management that we could do, even expounding it into both non-pharmacologic and pharmacologic approach. So just to emphasize on these 2 most common symptoms that are seen in patients with heart failure, and one is breathlessness, which could occur in up to 90% of patients with enhanced heart failure. They have advocate or recommending these 2 approaches, which are non-pharmacologic and pharmacologic. And for just to mention a few, for pharmacologic, we could give benzodiazepines or opiates to relieve this symptom. Then another symptom that we commonly see in patients with heart failure is the occurrence of pain. And they have again given these 2 approaches, which is non-pharmacologic and pharmacologic. So for pharmacologic, they have recommended that we could give anticonvulsants known as non-opioid medications or antidepressants. And just to continue with the list of symptoms that ESC 2020 has given, just to emphasize in here that depression, wherein it occurs in more than 50% of patients with heart failure, and the rate is even higher in those patients who are hospitalized, occurring in the range of 40 to 70%. So aside from doing non-pharmacologic strategies such as open communication, cardiac rehabilitation, exercise, and psychological therapies, we need to strongly consider referring these patients to psychiatry. So another guidelines is that strongly advocates palliative care in patients with heart failure is the ACC 2022 guidelines. In this one, they have strongly recommending high quality communication, conveyance of prognosis, clarifying goals, shared decision making, and also they have stated some recommendations on those patients who were placed with temporary mechanical support, and what option how these options can be discussed to them if they prefer that should be discontinued. And also advanced care directives should be discussed to patients as well. And on this slide, I just want to emphasize that they have given a class 2A recommendations for those patients with advanced heart failure with expected survival of less than 6 months, because in here they are advocating that we need to do a timely referral to hospice care, because in these guidelines, they have found out that cardiovascular death in hospice care is lower as compared to deaths that occurred at home at 8.2% versus 30% respectively. So what are the main goals of palliative care in heart failure? And we have identified two. One is to relieve and prevent progression of suffering from the consequences of heart failure, and to promote the best quality of life for both the patients and their families. And we have adopted two palliative care pathways. First one is early integration of palliative care in the care plan. And these patients would include complex congenital cardiac disorders, those with complicated cardiovascular diseases, and cardiovascular patients with coexisting chronic medical illness. And the other palliative care pathway that we have adopted is part of an advanced medical care to optimize overall clinical care. And this is given for severely ill patients despite advanced medical and surgical management, and for patients on end-of-life care pathway. So the next 3 slides would be more specific on type of patients that can be enrolled. So patients for early integration to the palliative care pathway are those patients who are on a state of optimized medical management, but progression of their illness is anticipated due to the following conditions. Either they have significant comorbidities, or they would require more than one surgical intervention, or patients who would refuse to have other intervention and would just opt to undergo medical management, or to those patients who are identified to be in need for psychological and spiritual support. And also, early integration of palliative care should be instituted for those patients with episodes of decompensation despite optimal medical therapy. And these are the other clinical case entities which may be considered for early integration. So those are the following. And for patients with advanced state of heart failure, or NYHA 3 and 4 symptoms, palliative care should also be advised or strongly recommended. The definition for advanced state of heart failure of the following hospitalizations: those with poor quality of life, or who are considered in the NYHA class 4, those who experience persistent edema, those who are intolerant to ACE inhibitors or beta blockers, those with signs of cardiac cachexia and experiencing progressive renal dysfunction, and those who are also experiencing frequent ICD shocks and with irreversible progressive illness. So this would be my last slide. And just to answer, why must PHC include a palliative cardiovascular care program in its patient portfolio? Because evidence showed that PC reduces hospitalization and improve quality of life. And this is the mission of PHC, which is to provide comprehensive cardiovascular care enhanced by education and research that is accessible to all through patient-focused care, compassion, integrity, respect, and excellence. Thank you for your kind attention.
Thank you very much, Dr. Yanesa. Indeed, we know that we really must have this program from the adult cardiology perspective. And now let us listen to the pediatric cardiology perspective on why should we have this cardiovascular program. To give us that topic is Dr. Christine Gay Tria from the Department of Pediatric Cardiology. Let's listen to her talk.
Good morning, everyone. I'm Dr. Christine Gay-Tria, and I'm here to talk about why is there a need for a pediatric palliative care program in the Philippine Heart Center. There is a famous quote that goes, "No parent should have to bury their child." While no parent would want to see their child die, suffer, or be in the slightest bit of pain, this is not usually the case for families with a child who has advanced heart disease. 15 to 20% of children with advanced heart disease have high-risk complex cardiac conditions. Pediatric cardiac diseases with advanced or complex scores are those with single ventricle physiology, tetralogy of Fallot with pulmonary atresia, double outlet right ventricle, complete atrioventricular septal defects, pulmonary vein stenosis, and severe valve diseases. With the current advancement in the field of congenital heart surgery, interventional pediatric cardiology involved in goals of care and advanced care planning, longitudinal support to families, symptom management, complex decision making, and for hospice referral or care coordination. For some families, however, they may feel that involvement of palliative care would mean that they are giving up on their child. And because of the unpredictability of outcomes in complex cardiac conditions, they may be discouraged to discuss goals of care. In a study done in Utah, they noted that pediatric palliative care consults are common in patients classified under RACS category 3 and 4. These patients are the one who underwent Fontan procedure, systemic to PA shunts, mitral valve repair or replacement, pulmonary artery banding, arterial switch operation, atrial septectomy, and TAPVR repair. In a study done in Boston, wherein they compared early years when subspecialty palliative referral was not so common to later years where there was an increase in pediatric palliative care referral, they noted that there was an increase in survivors to discharge at 97.5% compared to 96.8%, and a decrease in inpatient deaths at 2.5% compared to 3.2%. They also noted that those who were not referred were significantly younger. Patients who were referred to palliative care program had more advanced care planning, meetings, and resuscitation status documentation, which resulted in less interventions in the last week of death, such as cardiopulmonary resuscitation or defibrillation. In addition, there was significantly less hospital charges in patients referred to palliative care on the day and in the last 7 days before the patient's demise. Studies have shown that parents of children who died of advanced heart disease reported late recognition that their child would not survive, and there was poor correlation between parental and clinician perspectives of the child's illness. Palliative care referral was associated with fewer deaths, shorter hospital and ICU stays, and fewer invasive interventions. Moreover, patients with palliative care consult were more likely to die at home, with care focused on patients' comfort. Thus, benefits of a palliative care program would include continuous support of the child and family, improvement of communication, including regular individual information, if appropriate even for the patient, improvement of prognostic understanding and timely advanced care planning, early anticipation and comprehensive assessment of symptoms and suffering in the patient and the family, assessment of anxiety and fatigue, awareness and improvement of quality of life of the patient and the family, and lastly, support of the attending teams and healthcare professionals. Thank you.
That we truly need the Palliative
Morning, everyone.
Cardiovascular
I'm
Care
Dr.
Center in our institution. While we are an acute medical center to treat cardiac diseases, we have the obligation to address the other needs. And in this part two, we shall answer the question, how can the PHC Palliative Cardiovascular Care Program enhance patient care and overall client satisfaction? So colleagues, let us now welcome our chair for the Psychiatry and Behavior Medicine section, a member of the committee, to speak about the role of psychiatry in palliative care. Thank you, Dr. Icasiano.
Good morning, everybody. My lecture is about the role of psychiatry in cardiac palliative care. Um, Patients with heart failure have significant symptom burden, care needs, and often progressive course in end-stage disease. Patients with advanced heart failure often suffer from multiple mental problems, psychological sequelae, and of course, complex decision making because of their disease trajectory. Psychological symptoms are common among palliative care patients with advanced cardiac illness, and their quality of life can be as significant as the physical illness because of the psychological problems. Addressing the psychological need is part of the multidisciplinary approach that seeks to improve the quality of life through the relief of suffering and, of course, give the needs of the patients and families. What are the sources of suffering in advanced illness? There are so many alphabetical. I did it even alphabetically. No, of course, there's abandonment. Very common, anger, anxiety. You see anxiety not even just in advanced illness. Even in just regular illness. Okay, bereavement, boundary setting, burden, very common in Filipinos. No, caregiving is very hard, especially in late stage. No, um, coping, okay, very, very difficult also. I see a lot of delirium in the ICU. Again, very common denial in the Filipino. Okay, Dr. Yanesa mentioned about 50 to 70% of patients having depression, dignity in death. Okay, a lot of them experience distress and fear, and of course, because of the use of pain management medications, substance use, hope and hopelessness, difficulty of sleeping, because not only of psychological reasons, but of course because of medical reasons. There is of course loneliness and issues of love, okay, and personality issues, especially people who have had issues even early in life. Although not very common in the Philippines, I still encounter some suicidal ideation in patients in end-stage disease. Professional burnout, I also encounter when I was doing cancer palliative care early in my career. Psychiatrists also help in management of pain. We also facilitate the process of life closure, like supporting intimacy in relationships, even when nearing the end of life. Okay. The role of psychiatrists are many, like, first of all, we provide diagnostic expertise. Uh, Sometimes it's very difficult to differentiate normal sadness from adjustment disorders and from regular anxiety and depression, from clinical depression, which ones really need antidepressants and which doesn't, okay? Distinguishing psychiatric symptoms that are usually under-recognized or underappreciated, differentiating delirium from dementia. all of which contribute substantially to the burden of suffering for both patients and relatives. They may present as comorbidities, but they're still part of the disease. Symptoms, whether they are anxiety, whether psychosis, or even depression, there are also maybe expressions of their difficulty in coping with the disease or coping with the nearing death. Okay. Psychiatrists also provide treatment for psychiatric conditions. As I mentioned, giving of antidepressants, sometimes a lot of palliative care physicians are not comfortable in giving psychiatric medications. Also, non-pharmacological interventions like relaxation techniques, okay, and most especially psychotherapy. Very, very few are comfortable in talking to patients, okay? I don't think many of you would like to talk to them like I do, 1 to 2 hours. Okay. Provide education about psychological care. Of course, with the help of the team, proper information to both patients and family is very crucial. We also assist in also caring for the family. Other roles that the psychiatrists do are help with challenging communication tasks, support clinicians and other staff, sometimes even clarify ethical concerns, whether he is competent to reject medications, okay, help, and of course, develop research efforts. I think Dr. Renuevo talked about this. So in conclusion, patients with advanced cardiac illness frequently experience symptoms that will benefit from psychiatric care. And psychiatrists familiar with the basic tenets and issues of palliative care can make major contributions to the care of the seriously ill cardiac patients. Thank you.
Thank you very much, Dr. Icasiano. Mula sa puso, pumunta tayo sa brain. And Dr. Icasiano speak about the importance of mental wellness. Now we proceed with the other aspect, and this is neuropalliative care, which Dr. Maricar Lumol, who is the head of the section on neurology, a member of the committee. Dr. Yumol is both an internist and a neurologist. So let us listen to her talk.
Good morning. I was tasked to talk on the neurological aspect of palliative care. We all know that palliative care focuses on improving the quality of life for patients with serious illness, and that neuropalliative care is an approach to care that focuses on optimizing symptom management and functional status. We address the goals of care. We discuss advanced care planning and engaging in shared decision-making in patients with neurological conditions throughout the course of their disease. Now, patients with a variety of neurological conditions would have substantial unmet needs that can be addressed through specialty palliative care. And this includes conditions like severe strokes, whether an infarct or a hemorrhage, a poor grade subarachnoid hemorrhage, status epilepticus, patients who went into cardiac arrest, patients with underlying dementia, developing metabolic encephalopathies or delirium while admitted in the hospital. Now, other conditions needing palliative care, but not in the acute care setting like in the Philippine Heart Center, include migraine headache, multiple sclerosis, Parkinson's disease, unless they develop medical conditions or medical illnesses requiring acute care, brain tumors, myotrophic lateral sclerosis, etc. Now, this topic will discuss care as it applies to patients with neurological conditions, focusing mainly on stroke. Now, let me start this talk with a recently referred patient, 76-year-old male, who was admitted for elective bypass. He had sudden cardiac arrest from profuse mediastinal bleeding in the saphenous vein graft. Emergency exploration was done, and later on, the patient was referred due to anisocoria. He had hypoxic brain injury and massive stroke on neuroimaging, as you can see in the left side of this screen. So So there is an infarction in the right side of the brain, almost the entire half. Now the GCS is 5 with some myoclonic jerks, anisocoria, and minimal brainstem reflexes. So what would be the goals of care for this patient? Again, let's go back. No? What would be the approach to care? First, we must optimize the symptom management. So we medically decompress this patient. We have referred him to the neurosurgery service. We were able to control the seizures of this patient. Second would be Second is to address the goals of care. So in addressing this, we should have a complex interaction that requires an intricate knowledge of the clinical realities as well as the prognosis of this case. We should have an understanding of the patient's values as well as his preferences and priorities. And we should have a skill at responding to emotions of the relatives, and how do we break the bad news to them. Okay. Third would be to discuss the advanced care planning. What would we do in this kind of situation wherein the patient suddenly develop a massive stroke with status epilepticus? And then, of course, we should engage in shared decision making. This patient had a severe stroke based on the NIHSS score that is almost 42. He has a significant disability. The MRS score is 5, wherein he is fully dependent on the healthcare workers for all his needs. This patient also developed status epilepticus because of the anoxic brain injury, and this could have a mortality rate of up to 80%. So remember, this patient has a dismal prognosis, no? Let me again share to you the impact of stroke, because globally, stroke kills over 5 million people every year. And this is the leading cause of chronic disability, as well as the second leading cause of dementia. Now, patients who survive the initial period will still face an all-cause mortality risk of about 28% at 28 days or 1 month, 41% at 1 year, and 60% at 5 years. So almost 5 times the risk of death compared with the general population. Now, advances in the treatment of acute stroke have led to a reduction in the mortality and morbidity. And clinicians will then be faced an increasing number of survivors who, along with their family members or the caregivers, will experience a wide range of physical, psychosocial, as well as existential suffering, such as pain, mood, caregiver strain or fatigue, and end-of-life care needs. Now, these high rates of morbidity and mortality after stroke emphasize the importance for clinicians to integrate palliative care into both the acute as well as the post-acute systems of stroke care. Now, for patients who have a stroke, palliative care can begin at the time of presentation and can be offered concurrently with acute treatment. Now, the degree of palliative care integration depends upon the patient and, of course, the hospital factors. Now, the role of palliative care may be more significant for patients who experience marked functional or cognitive challenges, or for patients confronting dependency on life-prolonging measures such as your mechanical ventilation or enteral feeding or NGT feeding. Now, after a stroke, a variety of symptoms occur secondary to the direct consequences of the brain injury and the sequela of immobility, the loss of function, as well as prognostic uncertainty. Now, managing the symptoms of these patients who had a stroke to optimize function is integral to the palliative approach to care. And one of the most common symptoms after stroke is pain, occurring in 30% of patients after a stroke. And this includes headache, central post-stroke pain, spasticity-related pain, and musculoskeletal pain. Dysphagia is also common, and it occurs about 50% of patients in the acute setting. Depression is also common, as well as anxiety. Now, let me share this slide with you to differentiate palliative care from hospice care. Hospice provides medical care and support services for patients at the end of life. And this emphasizes symptom control as well as quality of life rather than prolonging the life. So what would be the differences between the two? In palliative care and in hospice care, these comprise physical and social relief um, functions, no? And they also focus on the quality of life. This involves also multidisciplinary team approach, but in the palliative care, this can be provided in any stage of the disease. But in hospice care, usually this involves patients with dismal prognosis, wherein they could have a prognosis of 6 months or even less. No? In palliative care, they may be involvement. They may involve there may be a concurrent curative treatment, but in hospice care, this excludes curative treatment. So in our patient whose prognosis is quite dismal, maybe hospice care may be provided. So what would be the eligibility for hospice care? Again, prognosis should be less than 6 months with inability to maintain hydration and caloric intake, with history of pulmonary aspiration, and dysphagia that is severe enough to prevent the patient from continuing food and fluids necessary to sustain life. Now, imaging features that support hospice eligibility includes a large volume of stroke or hemorrhage. And in our case, we have a patient with large right internal carotid artery infarction, wherein the entire half of the brain is affected. And medical complications that support hospice eligibility includes aspiration pneumonia, refractory decubitous ulcers, sepsis, pyelonephritis, and fevers, despite antibiotic treatment. And what would be the factors predictive of hospice enrollment among patients with stroke? This includes stroke severity, older age, female sex, a diagnosis of dementia, and hospitalization that is quite prolonged. So in our case, so what have we done for this? What are we going to do? What would be the further management for this case? Thank you.
Very much, Dr. Yumol. So we will now proceed with the next speaker, Dr. Edgardo Iba, who will speak on how do we do with the early integration of palliative care among patients who are suffering from heart failure. Welcome, Dr. Iba.
Welcome to Thank you.
Good morning. I was tasked to talk on the
Since we have different goals in cardiac rehab, it's really very difficult to involve. But there is a one published in ESC regarding the in 2020 regarding the role of palliative care for people with existing heart failure. Okay, now we know okay, we know very well that palliative the WHO, sorry, and kinareko niyan pero paglabas siyempre. Palliative care for heart failure, that of course WHO recognizes the need for all palliative care to all people have incurable disease. Okay? Of course, when we think about incurable disease, what comes to our mind is, of course, the cancer, cancers, yung mga blood cancers, yung mga bone cancers, those things, usually cancer talaga pumapasok. But remember also that people with heart failure who declines belongs to the incurable disease. And the role of palliative care is that it's very important to integrate this, especially in identifying symptom management, drug adjustments, uh, discussing with the family and the informal caregivers who are always around with them. That would be the role of palliative care. Our goal for this, why do we want to do this? Of course, we want to aim at the relatives and the other things that I mentioned to reduce the sufferings, not only of the patient, but their loved ones as well. As well as, as possible, a decrease in hospital admissions. Now, as I've mentioned earlier, palliative care is being recommended for people in curable disease, but may still respond to disease-modifying treatment. Not only that, it should includes patients who has a decline in the quality of life, the relationship to other people, and the persistence of symptoms. What is recommended in the journals that I've encountered is that it should be introduced early in the disease. If possible, all patients belonging to class 2 functional capacity of heart failure, wait, paano ba to? Decline. Okay. If possible, all patients identified as functional class 2 in heart failure should already be referred so that early intervention could be applied. And what are this early intervention? Of course, that's incorporation of your exercise, the lifestyle modification, dietary modification, and of course, psychological or psychiatric intervention. This would be very hard to apply if you refer already in stage 4 heart failure. That's why it's recommended that as early as stage 2, palliative care should be for cardiology patients should already be recommended. And you provide this along with the optimal medical management and care side by side. You don't provide them one at a time, but side by side. Okay, thank you. Okay, what's recommended is that for us to be able to provide, it should be integrated with what is being currently practiced, what's being currently published and practiced by the cardiologists. Now, symptoms that persist despite optimal guidelines should trigger a palliative care approach or intervention. Kaya lang, if you do that, it might already be late. So, as I've mentioned earlier, the patients belonging class, functional class 2, as much as possible, you convince them and their family to be enrolled or to be referred to a palliative care program. And the last one with advanced end stage heart failure, but that's a difficult, that's already difficult to handle when you're in end stage heart failure because they get irritated, so they would hardly move and they would hardly move about. Triggers, what are the triggers? But should introduce, hindi yung triggers introduce natin na. It should be introduced early to identify the trigger as the triggers as the disease progresses. Okay? Triggers should include distressing symptoms, recurring heart failure exacerbation, progressive frailty of caregiver concern. Other things that we have to consider are refractory heart, of course, yun na rin yung refractory heart failure. Although we do not have it here yet, patients on left ventricular assistive device, we don't have it here in the Philippines, but it is recommended na dapat naka-refer sa palliative care yan. And those patients who you identify as having a suicidal risks, you should be able to refer them early. Palliative, of course, the cardiologist would be managing all the symptoms, no? But as I've said earlier, the palliative care should be managed side by side or hand in hand. Because these things needs to be addressed. Like for example, breathlessness, the symptom of heart failure, breathlessness. This in early stages of heart failure, you can provide appropriately tailored exercises, including breathing training, neuroelectrical leg muscle stimulation, use of walking aids or hand fan. However, in the late stages of heart failure, what probably we can do is proper movement that would lessen their fatigue and that would lessen the symptoms. Proper movement and how they should go about their mostly it's more of encouraging them and more of teaching them the right things to do. Pain should be addressed because chronic pain results into a decline in the quality of life because people would be afraid to move. People would be because they're afraid that they would go into heart failure or have a heart attack if they have the symptoms. And one thing that I've regularly I've noticed naman in our patient is that some patients really have fatigue and depression. And this is important to address. The team should be referred to the psychiatrist or psychologist in the team of palliative care or in the team of the cardiologists to be able to make the move about. Otherwise, they would always be complaining of fatigue. They would always be complaining of they're tired. They would also complain that they cannot do things. Well, it's actually depression. And as this progresses, it would promote decompensation. And we know that if this progresses, it may lead to depression and for anxiety and further depression, which would lead to poor self-care, decreased medical adherence. Of course, they're already parang they miss taking in their meds, and a difficult thing that you will be encountering is that the overlap of heart failure symptoms with depressive symptoms. Sometimes it's very difficult to differentiate. Sometimes your PE may be, for example, your breath sounds may be clear, but they're complaining of shortness of breath. So it would be very difficult to know if these are depressive symptoms or really related to the cardiac status of the patient. And with this, it would be associated with reduced functional performance. So you see, all of this would require behavioral therapy and to some extent, exercise training for those who can still tolerate. This would be the end, but what is important is advanced care planning should always be done. The relatives and the caregiver should always be involved. Meaning, as the disease progresses, the group or the doctor in charge of the palliative care should be already talking to the patient and to the family. And they are planning, as a group, they already have a plan on what to do next. And also, although this is not anymore the role of but the individual cardiologist, we should also be reviewing their meds. That maybe they should be continually evaluated. And for that is the main goal, the main role of cardiologists in palliative care. Thank you very much.
Thank you, Dr. Eva. Well, mga kapatid, napakinggan na ho natin na pwede naman palang i-rehab ng maaga. Hindi na kailangang mag-intay pa. Pero kakayanin ko ba ang rehab? Kakayanin ko ba ang iba pang problema tungkol sa pangangalaga sa puso? So ngayon naman po, makikinig tayo kay Miss Agnes Balid. Ang ating pong pinuno sa social service section, Ma'am Agnes, to discuss the role of the social worker in palliative care.
Good morning, everyone. So I'll be discussing briefly the role of the medical social worker in palliative care team. So it's here stated the provision of psychosocial services to patient and their immediate family. So we have also in the medical social service unit, we have also our assessment tool that we determine the priority of the needs of our patients. So early conduct of assessment or interview help us to identify the priority needs of our patients after referring to us by the medical staff. Then the navigation of community resources, we also do that because this is one of the main problem identified, most of whom, especially patients that are sometimes left abandoned of their family members. So this navigation is very important. For example, we have encountered one geriatric patient. We referred to East Avenue Medical Center and also at the Veterans Memorial Medical Center. So those are one of our services, including identification of the available hospice care within the community where the patient resides po or live. And then we also identify support groups in the community that can help the family sustain in the management or case management of the patient. Then the social protection, of course, during the patient confinement, we assist to navigate if patient has social protection, enrolled po ba yan sa PhilHealth, may social insurance sessions. So those are also a few of what we do to assist the palliative care team. So this discharge disposition and planning, we also, that's why early referral and interview for us, for the medical social workers, ito na po yung part ng aming discharge planning because when you identify problems, you can already have an idea sa upon referral pa lang kung meron pong intensive interview. That's not only covered pati ang patient pero yung information about the family. So we also address the patient safety issues pertaining to the environment and concerns such as potential abuse and neglect. Because this it is a real-time mga problem po dahil we have a lot of patients referred to us that nobody wants, even if this patient has family, but there majority of the cases, they don't want to be involved and take care of the patient since it entails a lot of management. So that is one of the role that we, of course, with the help of other profession. So we explain and we help the family understood the role of during the treatment plan, even after the discharge of the patient. So this conflict mediation in the family, there are cases also referred to us. For example, the one that we referred to, Viluna. So we learned that hospital has a daycare services because the social service take cares of the pension plan of the patient. Because the family members, they want to have that the social pension. So it leaves now nothing for the patient. So the role there of the medical social worker is to take care of the finances of the patient. So also here, very basic po ito, provision of financial resources, the available government and non-government funds, available government and non-government funds that we can offer to patient and families, therefore lessening their financial constraints or financial problems when it comes in paying in the hospitalization. So we have here, most of us, we know naman the Malasakit program, which composed of the PhilHealth, the funds coming from the other government agencies, such as the SWD and PCSO, and the different legislators fund na marami naman pong available. So we navigate and during the engagement with family, so we give them a list. We even refer them actually for these available fund resources po. So just this a process of referral when patient refers to us. But I'd like to reiterate that even these patients are referred, of course, they are still a pay patient. We just help in, in the financial aspect po and other concrete services. So ito po, this is also clear. Then the referral coming from the attending physician or other health care professionals. He identifies patient as high risk, identify the problems. A patient with high risk needing social service assistance, then refer to us. Then the medical social worker conduct assessment, identify presenting problem, conduct intervention planning, collaborate with other healthcare professionals, continuous engagement in monitoring and reassessment even, then evaluate the process, where are the goals achieved or not. So if yes, so termination, meaning discharge of the patient, and then ito po yung isa is the patient applies for assistance. This is a very brief explanation of the process of referrals. So there is an end to cure, there is no end to care. So that would be all. Thank you.
Thank you, Ma'am Agnes. Yes, there's an end to cure, but there's no end to care. And maybe, Ma'am Alice, naririnig po yata yung kahilingan nyo kung saan nyo ipapadala. So, ang susunod po nating panauhin ay isa nating bagong kasama, ang ating Philippine Heart Center chaplain. Siya po ay si Father Eliseo Navarro. At kanya pong gustong i-share sa atin ang tungkol sa Camillus Nursing Homes, the nursing homes with humanized care. Let us see the movie.
St. Camillus Medhaven Senior Living Community is a group of nursing homes with 3 facilities. St. Camillus Medhaven Nursing Home Main Branch, St. Camillus Medhaven Dementia Village Annex, and St. Camillus Nursing Home Antipolo City. St. Camillus Medhaven is run and owned by the Order of the Ministers of the Sick, popularly known as Camillians, whose mission is to manifest the merciful love of Christ to the sick. Our vision is to provide a home, a nurturing community, and a center for excellence for holistic care of the elderly and persons in need of convalescent and palliative care. Our mission is to commit ourselves to care for our stakeholders with heart in our hands, by accompanying and serving with compassion and confidence, respecting human dignity and individuality, and upholding excellence in all services. We boast ourselves with state-of-the-art infrastructure and equipment, specifically designed with international standards for aged care residences, having smooth leveled spaces, spacious rooms and common areas, ramps, grab bars, smoke and fire alarm system, special bath facility and trolleys, ambulances, and transport shuttle. Here at St. Camillus Medhaven, we ensure that our residents are safe, healthy physically, mentally, and spiritually, and feeling at home.
Mabuhay! You're most welcome here at Camillus Medhaven, your home with a heart.
Our mission of serving the sick here in the Philippines started in the year 1992, and we started it from our present ministry in orthopedic hospital in Manila. So yeah, our identity as chameleons is really to serve the sick with hearts in our hands. That is always our tagline. So we believe that service to the sick is really a common call for all of us. And this will be our goal who will be admitted to our institution. So probably those with medical conditions like Alzheimer's disease, recovering from stroke, Parkinson's, depressions, and recovering from cancer. So by now we have 120 patients with ambulatory condition, bedridden as well as yung may mga Parkinson disease. And during my time when I was the administrator of this institution in the year 2011 until 2017, we had this process of admission para ho mas madaling ma-accommodate ho yung mga gustong mag-avail ng aming services. So a family of the person to be admitted is asked to visit Camillus Midheaven for the ocular visit. And for those who are interested, will be given the application form to be signed by the guardian of the family. Most likely kasi ang lahat ng kinikater namin ng mga residente ngayon, yung mga anak kasi nasa ibang bansa. Kaya most likely, yung kanilang mga nanay at tatay iniiwan sa aming facility. Now, I do believe it's not all about abandonment, but it is more giving the appropriate and holistic care of their parents. Kaya nga, our team of Camillus Midheaven will conduct a visit to the residents of the family, to the person to be admitted. So, ang institution din namin, nagkakaroon tayo ng memorandum of agreement para po doon sa mga clarity kung ano yung mga conditions na kailangan po maintindihan ng mga family members na gustong mag-avail ng aming services. The admission committee meets a day after the conducted family visit for admission assessment. Then clearance of admission will be secured from the doctor of Camillus Midheaven. So we have now a regular visiting doctor from our own hospital also in St. Camillus Medical Center in Pasig. The family will provide the payment assigned memorandum agreement and as well as the power of attorney. Kasi po kailangan naming ma-secure na bago ho iiwan yung kanilang parents doon sa facility, meron ho kaming clear instruction and direction how to administer yung kanilang mga magulang. Kasi most likely, isa sa mga kondisyon na nandoon, dapat alam ho namin kung saang ospital at sino ho yung contact person na magiging immediate guardian noong family member na nandoon sa facility. So hopefully, with this present and short presentation, you may have a full understanding paano po magkakaroon ho ng tie-up yung program ng cardiovascular program ng Philippine Heart Center in tie-up with our institution, the Camillus Midheaven Nursing Home. We believe that with our humanized care, we are going to serve our sick brothers and sisters, putting more hearts in our hands. Thank you.
Maraming salamat. Maraming salamat po, Father Eli. May isa pa tayong session, part 3, at ito ay importante, mahalaga sa institusyon ng Philippine Heart Center, being a tertiary training hospital. So we will have 2 resource speakers. And the first talk shall come from the Department Manager of Education and Training. Sir, move up ako natin to. And this is from Dr. Ranulfo Havelosa, Jr. Let us listen to his presentation.
And good morning to all of you. And now for my presentation on how can this palliative cardiovascular care program enrich the education and training of our residents and fellows, even our nurses. Palliative care is defined as the prevention and relief of suffering of adults and pediatric patients facing problems associated with life-threatening illnesses. And this is not limited to cancer patients, but we have this group of patients in our center that we see every day. And this program should be applied by all healthcare workers at all levels of healthcare systems, from primary providers to generalists, specialists in many disciplines and various levels of palliative care training and skill, from basic to intermediate to the specialist.
Apologies for this technical. Iba yung layout.
Pleasant good morning to all of you. And now for my presentation on how can this palliative cardiovascular care program enrich the education and training of our residents and fellows. Even our nurses. Palliative care is defined as the prevention and relief of suffering of adults and pediatric patients facing problems associated with life-threatening illnesses. And this is not limited to cancer patients, but we have this group of patients in our center that we see every day. And this program should be applied by all healthcare workers at all levels of healthcare systems, from primary providers to generalists, specialists in many disciplines and various levels of palliative care training and skill, from basic to intermediate to the specialist. The World Health Assembly resolved in 2014 that is the ethical duty of all healthcare professionals to alleviate pain and suffering, whether physical, psychosocial, or spiritual, irrespective of whether the disease or condition can be cured. There are many barriers to the development and accessibility of palliative care services. And this is not only for the dying, but for any patient suffering with serious life-threatening health condition. And we deal with this every day, from the ER to the OR, CCUs, post-op ICUs. And this is not an alternative to disease prevention and treatment that should be integrated. Palliative care that only relieves suffering, but also anticipates and prevents it. It's a massive burden of unnecessary suffering due to pain and other physical symptoms, psychological and social and even spiritual distress. This is essential in achieving the national universal health care. Other barriers like lack of national palliative care policy, though there is a 2018 published guideline, and the lack of basic, intermediate, and specialist training programs in palliative care in many hospitals. There is even lack of inpatient and outpatient staff positions that include palliative care as an official responsibility. Even the insurance coverage of palliative home care is not covered. In 2018, the National Coalition for Hospice and Palliative Care published this 4th edition of National Consensus Project, Clinical Practice Guidelines for Quality Palliative Care. This can be integrated to our training programs, even with our residents, fellows, subspecialties, and our nurses, from basic level to the specialties. Those care frequently for patients with serious or life-threatening health conditions. The physicians who complete basic palliative care training should be empowered to prescribe morphine and other pain relievers to inpatient and outpatients. And this should be integrated in our subspecialty trainings. Basic palliative care training for practicing nurses should also be part of this program. So people who can be involved in palliative care with all the consultants, staff and visiting, all our residents and fellows and subspecialty fellows, our staff nurses, both in the critical and the non-critical areas, even our psychiatrists, social workers and psychologists, pharmacists, and even the family caregivers who will continue the caring at home. The patient goes into hospice care or even to home care. The palliative training program is multifaceted, even the end of life care. And these are the some of the aspects that should be taught, should be included in our curriculum. The goals of care should be part of this advanced care planning. What happens when surgery or treatment fails, or what's next with every step of management. How to communicate the bad news that there's nothing we can do. Pain management, which usually relegated to anesthesiologists, should be introduced to our trainees. Dealing with depression, anxiety, mental changes, when to withdraw or withhold medications and treatment, dealing with the last hour of living, end of life care, legal issues, addressing the many gaps in palliative care, and the various elements and model of end of life care, so psychosocial and issues, and even sudden illnesses, infection, now with this recent COVID. So we have an opportunity now to include this, and we are studying and how to integrate this to our training program, and this would really enrich our training program for our residents and fellows, and even for our staff nurses. Thank you very much for your attention.
Good day. I am Dr. Consuelo Suarez, and I'm discuss research and palliative care. In the strategic map of the Philippine Heart Center from 2017 to 2022, one of the core process is research, and the priority of research is primary and secondary prevention of rheumatic heart disease and coronary artery disease and ischemic heart disease. I think with palliative care, there will be a change in some of the priority of research, because palliative care is not primary and secondary prevention. Now, what is palliative care? Palliative care in cardiovascular diseases is an interdisciplinary care that aims to relieve suffering and improve quality of life for persons with serious illness and their families. It is offered simultaneously with disease-oriented care, which is unlike your hospice or end-of-life care, usually in patients with cancer. So let's talk about terminology, because I think terminology will make us accept what palliative care is. Now, supportive care is the prevention and management of adverse effects of disease and treatment. It enhances rehabilitation, secondary prevention, survivorship, and end-of-life care. So it only does not encompass end-of-life care, but also secondary prevention. No? So it would like to increase the lifespan of a patient. Now, your palliative care or end-of-life care is perceived as an obstacle because it destroys hope and causes stress, because at the end, it is always death, which is the end result, and it sends a negative message. A study in Belgium among pulmonologists and cardiologists said that palliative care emerged as having a bad reputation with unpleasant connotation for patients and family members. The prognosis of heart failure and chronic obstructive pulmonary disease is difficult to define, is not identified with death in mind. No, always not death in mind, but to prolong life. Now, so what will we use as a terminology? Is it end-of-life care, palliative care, or supportive care? Some are going for your support care rather than your palliative care. So that's a question that we have to think of and answer when we do our heart center palliative care. Now, how about prognosis? Now, heart failure has an extremely variable clinical course. So usually acute phases of heart failure is intermixed with phases of prolonged relative stability. With this, there is a difficulty in formulating short and medium-term prognosis with these patients. So, question is, will prognosis be used in deciding to start palliative care? In some studies, they have a surprise question to identify outcomes. And the question is, would I be surprised if this patient died in the next 12 months? A negative response was correlated with mortality at 1 year. Now, but the specificity of is 44% and 59% among cardiologists and nurses, and the positive predictive value is 52% and 45% among cardiologists and nurses. What does that mean? If the answer is no or yes, it's a 50-50 chance. So it's not predictive. No, this question is not predictive. So there should be other ways to tell us when palliative care is needed or not. Now, what are the knowledge and attitude gaps of health professionals towards palliative care? One is really a clear concept of palliative care, end of life care, or support care. And cardiologists and pulmonologists attitude towards palliative care, because some will not really differ because they think that a palliative care is an end of life care. It is more a support care so that there could be prolongation of life. Now, correct timing of discussing palliative care to patients and relatives, because we know that, as I said, the disease process is a mixture of acute phase and interspace with stable phase. So when are we saying, telling the patient that the patient needs palliative care? Because they might feel that, remember, palliative care is always connoted with the end of life care. Now, determine which model where collaboration and effective communication among different health professionals will be effective. Because remember that it's an inter-collaboration of different professionals, and how would we communicate the needs and wants of the patient and relatives from one professional to the other. Now, how about the knowledge attitude of patients and relatives towards palliative care? They would want an understanding of the patient's uncontrolled symptoms, what is happening. So they would really want to discuss this and characterize and address the needs of the caregiver. So what are really the needs of the caregiver, not our perceived needs as professionals. Improve patients and families' understanding of the disease trajectory and the importance of advanced care planning. So as I said, our disease involved in cardiovascular palliative care has a waxing and waning trajectory. And determining the best models of palliative care, including models for those who want to continue life-prolonging therapies. Now, this is a paper published in the International Journal of Environmental Research and Public Health from Vietnam. It's the knowledge and attitude towards geriatric patient care among health professionals. Now, it's a cross-sectional study, and it used these questionnaires, palliative care knowledge test and the Froment attitude toward care of dying. Now, this has been translated into Vietnamese, and they did arrange the papers, the outcome measure, so that it will suit the need of the study. And this could be one of the primary or initial papers that could be done in palliative care. So with this, I would want to say maraming salamat po and good day.
Thank you, Dr. Suarez, for an insightful talk regarding research and palliative care. So at this point, I would like to invite the resource speakers to open their video and join us on virtual platform and also on physical presence. And we can now turn over the microphone to our moderator, our visiting medical staff, a pain specialist, Dr. Mylene Tiamson. It's a very interesting morning, Mylene. And I think from the presentations, we can see how things might evolve with our palliative care program.
Good morning, everyone. And as mentioned, I'm Dr. Maylene Vasco Tiamson. I'm an anesthesiologist and pain medicine specialist. And I'm happy to entertain your questions. If you have more questions, kindly type them in. I think we have one comment. This is not a question actually, but more of a comment coming from an anonymous source. But a phone-in question. Okay. I hope that the PHC Palliative Care Committee will also include the family who are also troubled and in need of specialized care. Siguro I'll answer that, Doktora. Actually, part of the palliative care continuum is bereavement care. So you really include the family from the diagnosis nga eh. And until the patient has actually succumbed to the illness, you include bereavement care. So involved talaga po ang family when you talk about palliative care. And also, a continuation of the comment is that we also need to prepare patients for discharge to ensure continuity of care at home if hospice care will not be availed. And I think this was answered by Ms. Agnes. But if, Ma'am Agnes, do you want to add on to what you do actually for the patients sa discharge disposition? Can you expand pa, Ma'am Agnes? Kasi baka hindi nila naiintindihan what discharge disposition actually means.
Actually, with the help of the other team members, we include the family in giving them orientation on what to expect, what to prepare, because I was able to attend a palliative care training for 1 week in Singapore. So all the details pertaining to the process of the patient when he's about to go. So yan lang po, with the help again of the other palliative team, ina-explain na mabuti po yan sa pamilya. Na ang death, eventually maintindihan nila na part yan ng, I mean, it's a process, ang death. So na hindi ganun ka, kasi mayroon tayong process of yung acceptance sa una pa lang when the patient is still admitted. So meron po yun, hindi yun bigla-bigla. So these are being explained, including the psychologist, psychiatrist. Ito po ay part ng pagpapaintindi sa case management o case process sa isang palliative care patient.
Thank you, Ms. Agnes. Actually, to add on to that, no, in other palliative care institutions po, like me, when I did my observership din po in Singapore, no, the National Cancer Center of Singapore, although this is cancer related, no, the social worker actually sits during endorsement rounds in the morning because the social worker has a very, very big role when it comes to palliative care because ini-endorse na agad ng social worker upon admission. Where will the patient be transferred once na-discharge? No? Admission pa lang yon. Alam na nila kung saan dadalhin, sa hospice ba ito, home care ba ito, or any other palliative care or hospice institution. No? Sino ba ang magpo-provide ng finances ng pasyente? And they make a pedigree, yun ang tawag doon sa official na, so sino ang pamilya who will be the first one, especially kasi pagka Singapore, alam nila yung finances ng pasyente. No? So it's very important that the social worker informs the family and even the physician. So from as an outsider coming in or looking into heart center, do you do that actually? Do you inform the attending physician kung ano ang financial status and dynamics of the patients?
Thank you, Mylene, for that question. Any of the cardiologists? Actually, maganda na nasimulan na itong palliative care program, but as we were emphasizing, this is cardiovascular palliative care, no? So we want everybody here to understand we're not talking about cancer here, but the Philippine Heart Center palliative program is palliative care, is palliative cardiovascular care program. And from the talks given this morning, there are two aspects that I think we need to emphasize to our participants, and especially to the medical staff. What we wanted is an early integration of the palliative care plans. And, and it goes beyond the heart. The brain is one of the most important, the psychological aspect, which Dr. Icasiano said earlier. And Dr. Eba also emphasized that even functional class 2 should already be considered as part of the palliative care. Now, perhaps one of the things that maybe others may say is, what's missing out? What about the nursing services? Technically, the nursing care of Heart Center is dealing with the acute care of our cardiac patients. And as they do carry out this function or role, they already provide palliative care nursing to our critically ill patients. And the reason why at the symposium we have not included something on the nursing pathway is because that will be our symposium number 2, Mylene, and that will be the essential role of nursing services in the implementation of the Heart Center Palliative Cardiovascular Care Program. So in the interest of time, do we still have questions or comments?
Sir, sige po. Sir,
Palliative care should not just be a specialty of a certain doctors, but it's a group, it's a comprehensive, it should be a comprehensive program. We should include the cardiologist, the psychologist or the psychiatrist, the nutritionist, the dietitians, and everybody involved in taking care of the patient. It should be a comprehensive program targeting to alleviate the symptoms and all the problems, not only of the patient, but also of the family.
to add on to that, actually, no, dito lang po kasi sa atin sa Pilipinas na parang ang palliative care is actually under the realm of family medicine. The training program is under the Department of Family Medicine, but generally po, in all other countries, anyone who has interest in palliative care can undergo a fellowship training in palliative care. I actually am undergoing a current fellowship training under the Institute of Palliative Medicine sa India in collaboration with the WHO. Ang makaklase ko po, pharmacist, nurses, journalist, businessmen who are all stakeholders in palliative care. So anyone who has interest in palliative care may pursue training in palliative care. And totoo po yan, it is a multidisciplinary team approach. But since it is multidisciplinary, ang isang pinakamalaking barrier po to palliative care is acceptance, even among us. So maybe anybody can answer, how do we actually gain traction and acceptability of the concept of palliative care in Heart Center?
We have Dr. Manso who would like to share his thoughts.
Okay, sir. Sige po. Dr. Manso, the floor is yours po.
First off, I'd like to commend Florian and the Palliative Care Committee for an excellent session. I learned a lot, but I must confess, I still do not have a clear concept of how we are going to implement palliative care or supportive care, or especially here in the Heart Center, end of life care in an acute care setting. I will be talking as an administrator, but I do not have my conscience tugging at me when I express some of these thoughts later, because I feel I am a compassionate doctor. I believe in personalized care. I really care for my patients. But because I am an administrator, I also have some other points of view that may not seem to be in consonance with compassionate care. We are an acute care center. And we already heard that palliative care is very closely associated with end of life care. And it would be nice if the end of life is short in coming, but sometimes end of life can be very chronic. And I wonder if we can afford to afford in so many ways. We're not talking about expense, we're talking about putting in personnel, training them. Even ETRS is talking about additional training for palliative care, as if compassion can be trained. And I think actually here in Heart Center, we really need to review what compassionate care is, because people are forgetting about compassionate care. Uh, I think also that there are some pitfalls that we especially the doctors have to be uh, more clarified on, so that we do not get into that stage where we need to talk about palliative care. One is that we still have a tendency, many, especially of our younger, less experienced, more hungry specialists, sometimes of offer false hope and expectation. So these patients who actually may not be served well with more advanced therapies are given the false hope that they're going to get good outcomes. And when they sour, it is hard for them to accept, and they keep on denying. And this is really a concept that we also need to talk about sooner than later. The concept of medical futility is something that is foreign for many of our fellow practitioners. They pour in all the resources as if there is something else that they can do. They cannot accept that what they offered is not what is happening, and it's hard for the family to accept it when even the doctors cannot accept the medical futility of the patient. I have some lessons in good governance which might prove useful for us here. Years ago, when we were challenged very severely by the government, when we were not being given funds, when we were expected to earn the funds to take care of the poor patients. So some of you are aware that now we have a very sweetheart deal with the government. They reimburse us for what we spend for indigent patients. When I was the administrator, I had to go to DBM and plead for more money. We need to go and explain each and every patient uh, that needs to be supported, as if we can make that projection. And we also know that we are not going to be given very much. And there was a time when we were told we were not going to get anything because we were doing it right. So what was right for them? Government does not give us money. We take care of the patients using our earnings from our private patients who do not really have enough to support indigent patients. So now we can support indigent patients. But to what extent? Let me just focus on the example of Maricar, a Zay benefit patient who is supposed to be standard risk, who is not supposed to die. PhilHealth does not support complex cabbage patients with mitral valve replacement because these patients will spend too much and might not survive. So if you pass J benefit, that means you have a very high, a very low risk of mortality. You are supposed to be a very good risk for a return, so a sort of return of investment of the national government in your health, so that you can go back and become a functional member of society. But you have a massive stroke. And the massive stroke will require, so I don't know what the outcome is. Nabitin ako doon, Maricar. Kasi kinwento mo lang take off, but you didn't tell us what happened to the patient. You had a neurosurgeon in. So I imagine the patient had a very stormy course, both cardiac-wise and stroke. You know that in NBB, that say benefit is NBB. So where does the money now come from to support the patient for the stroke and for the other complications? Maricar knows, neuro. I have not been very supportive about the Philippine Heart Center being recognized as a stroke center. I don't want us to be recognized for acute strokes. I hope and I can see the passion that all of you in the committee are showing, and I can imagine you'll continue to show it because we have this culture of excellence here in Heart Center. So I'm afraid that you might project the Heart Center as a very excellent center for palliative care. And I don't know how you will be able to talk to the patients. I want to come here for your palliative care, but you know, the heart center will not be able to financially subsidize you if you are not a heart patient. So anong gagawin natin sa kanila? We will accept them. Are we going to find a cardiac ailment for them to be included in the program? Your compassion, you know, you will not be able to prevent it. You will find ways to help. And when you find ways to help, it's going to be a big burden for the center. A big burden not only for the cost, but it also means they will occupy a bed for extended periods of time, which can be used for other patients who can come in and go out and go back to society. So uh, while we talk about personal care, while we talk about compassionate care, while there was a comment that we should also be taking care of the family and be concerned about what their needs are, the COVID pandemic put into the fore so many other things outside of a patient first policy. One of the things that I have learned through the pandemic is that we also need to take care of the greater good. Diba? Yung greater good does not necessarily mean taking care of everyone kasi talaga. It actually means we will not be able to perfectly address the needs of each patient, especially the very chronic patients. We might not be able to address the needs of the family who want to be there, and they will accuse us of being non-compassionate. Pero, sige rin, magalit na kayo sa akin kung magagalit kayo. Pero, sisihin na nyo kung sisisihin. Pero ang totohanan, we need to protect the center. We need to protect the healthcare workers as we protect the patient. So, Florian, tuloy mo yung ginagawa ninyo. Pero, I hope we can find a balance where we can project we are truly compassionate, but we are also compassionate for ourselves and for our future patients. Pag marami na tayong, ayokong sabihin, pag nagve-vegetable farming na tayo dito, mahirap mag-ani dito ng prutas pag ano. So we don't want us to bite more than we can chew. But sige, bite lang kayo ng bite and chew lang tayo ng chew until we're able to digest it properly.
Thank you, Dr. Manzo. Dalawa kaming sasagot. First po muna, mga kabayan, ang Philippine Heart Center po is not going to be a palliative cardiovascular care center. Philippine Heart Center will stay as Philippine Heart Center taking care of patients with heart ailment. In-emphasize namin yan. In fact, the reason why we were convinced when we were called into formed the Palliative Care Committee by Dr. Abanilla is when we reviewed on the guidelines by ACI. And it is going to be part of a comprehensive holistic patient care under ambulatory care services, inpatient services, perioperative services, and rehabilitation services. And that's exactly what we want to target. We want to see in the current care management plan of cardiac patients, When can we have an early integration of improving their heart functions? And that is by early cardiac rehabilitation. We want to see the timing of psychological evaluation. Yun yung mahirap, di ba, Doktora Icasiano? Sinong magsasabing ang pasyenteng ito kailangan ng makausap ni Doktora Tess ng 2 oras or ng kanyang pamilya? And that's where we are groping. But definitely, Dr. Manzo, the program can work without you spending money yet. And that's the reason why I hope Father Eli here will also be able to share the view how we will teach compassion, because it's the curriculum Dr. Havelosa was saying is that maybe yung communication will be part of the curriculum. And I'm so happy with the research presentation by Dr. Suarez, because we can start a research and find out what is the attitude, what is our attitude in terms of how to offer early integration to our severely ill patients. So Dr. Manso, basta humimerienda lang kami, happy na po kami. Ito po si Dr. Maylin, meron lang po siyang gusto i-share tungkol sa family.
Yung merienda, sagot ko, lahat ng gawin nyo. Basta huwag nyo papasagot sa akin pag 1 taon na nandito yung pasyente, 6 na buwan na nandito yung pasyente. Ang mahirap na ano yun. And wag natin gasgasin masyado si Accreditation Canada. Accreditation Canada, when we talk about all the standards and the criteria, it does not show how compartmentalized they are in Canada. I have my personal experience of my mom undergoing emergency craniectomy for subarachnoid hemorrhage. We thought she was a goner. She was brought into the acute care center. She survived the operation. She was well. And then she was transferred to, laging sinasabi nila, compassionate care. She was transferred to a rehab hospital without even any of us there. Hindi man lang namin inabutan doon sa ospital. Tinransfer ng ambulansya doon sa kabilang ospital. Hindi namin alam na ililipat na siya. Alam lang namin ililipat, pero pagdating namin, wala na yung pasyente. No, inaano ko lang na si Accreditation Canada, maraming kaya lang nga, they are so specialized, we think that they are referring to what one hospital should be doing. Yung dinidescribe nila, gagawin sa acute tong isa, gagawin yung compassionate, gagawin yung rehab. Sa ibang hospital, hindi because it is not really the way we have been doing our taking care of patients here in the Philippines. Sa atin kasi sa isang hospital, lahat nandun eh. And sometimes we think, dito sa heart center, lahat kaya natin, hindi natin kaya lahat eh. So itong compassionate, hanapan yung, sabi nyo, kailan tatawagin kailan natin tatawagin si Tess? Hindi ko tatawagin siya kasi yung pasyente ko, pag-uwiin ko after 3 days eh. Di ba pag nag-cabbage tayo, bago pa tayo ang tawag nito, palliative care kumbaga. Most of the standard risk patients should be going home 3, 4, 5 days after surgery. Pag lumagpas ka nun, mali na yung patient selection mo.
Siguro jumping off. Doc. Jumping off from your experience, sir, palliative care actually involves talaga the decision of the patient and the family member. So actually pagka po fully implemented and organized yung palliative care program, you actually can streamline your finances and mas maging efficient yung use of resources ng institution. Kasi pagka, halimbawa, hindi pa natin na-discuss yung advanced directives. Pag sinabi na ng pasyente na at the onset ng diagnosis niya na itong gusto kong mangyari sa akin, ayoko na ganituhin ako. Then pag na-admit siya, alam na natin na hindi mo na siya intubate, hindi mo na siya i-hook sa ventilator. Unlike pagka hindi po na-implement yung ganyan, no, wala tayong concept ng ganyan, no? Gagawin na natin lahat. And your limit is how far the patient's finances can extend his life. Ganun lang po. So with a completely organized and institutionalized palliative care program, you are able to respect the patient's wishes, the right to self-determination, be able to comfort the family, and create linkages para pag nakita mo na ay hindi na talaga to pang heart center, pang hospice na ito, i-link mo na siya agad. Hindi mo na patagalin. Yun po yung konsepto ng palliative care. And even yung training na sa communication, you don't need to spend much kasi we just need to tell our fellows, our residents, pagka pag sinabi mo sa pasyente, pronounced dead at this, palliative care is holding the patient's family member's hand, a tap on the shoulder, no? Kind words. These are part of palliative care.
Just one last retort lang. Tapos titigil na ako. What you're describing kasi is something I grasp and I completely agree with. Except that you raise concepts in palliative care that listen kanina, ako, I was listening. Sabi nyo, palliative care is not end of life. Palliative care is not the resort for medical futility. What Dr. Thompson described is end of life, advanced directives, medical futility, di ba? And there, I agree, we should teach our doctors how to be compassionate by telling them enough is enough, the suffering is enough, there is something more that we can do so we can move. Pero, yun nga kasi, dinefine nyo kanina, no? It is not that. So, yun yung ibig sabihin ko, I cannot grasp the concept of what we want to do with palliative care. Pero kung ang dinidescribe ng palliative care is to be able to address advanced directives, address DNR, address medical futility, you have my complete support.
Napaka-broad po kasi talaga, Doc.
Mga kapatid, gusto pa sana natin ng talakayan. Okay, si Doktora Abola, pagbibigyan ko bago ang ating final message. Yes, Doktora.
Hello. Again, I'd also like to commend the committee and enjoyed very much the presentation. When you spoke about linkages, you mentioned that. I just wanted to also share because in the course of working for heart failure guidelines, we came across family medicine specialists right now who actually are palliative care specialists. So there are 4 training programs of family medicine with palliative care. And maybe, I don't know if you've already started interacting with them, we can probably reach out to them and see how they can be the partner in the community. Like we see our patients here, we start palliative care as your concept had involved more integrative, compassionate care to start when the patient gets admitted, actually. And then partner with the family medicine if they have, for patients who might really need the continuing palliative care. Just that, sharing.
Tara, in relation to that, actually, in the midst of the pandemic, the DOH, in collaboration with all the stakeholders involved in the medical field, we actually sat down to make a manual of, kasi meron na tayong National Hospice and Palliative Care Program na mandated by the government, and we already sat down to make a manual of operations, procedures, and standards, which I am part of the technical working group. No? So we made a program, a manual, hindi pa lang po talaga siya naro-roll out, but it is a program po training people from the community, mga barangay health workers, and mga primary, secondary hospitals, coming from Apex hospitals po na determined by the government. Kasi ganun na po talaga yung lalo na if you look at the entire picture from a universal healthcare perspective po. Ganun na po tayo. So, wala tayong problema po pagka nag-institute tayo ng palliative care, cardiovascular palliative care program kasi yun na po in direction. pag na-identify natin yung patients, we can actually refer them to the community.
So, Doktora Maylene, ang palliative care, hindi lang talaga cancer. And because the other top three sa mortality and morbidity is heart failure patients, Dr. Manso, I think it's really high time we really find time on how we will implement this, the PHC Palliative Cardiovascular Care Center. So, I think hindi lang po Symposium 1, may Symposium 2 na po kaming niluluto with Dr. Crisel Galang. Symposium 3 yung susunod pa, no? Linkages. And thank you very much for the attendance. And it is our honor to have with us this morning our Executive Director, Dr. Abanilla, for the final message.
Hi, good morning. No, it's past 12. Good afternoon. First of all, before I forget, I would like really to express my thanks and heartfelt gratitude to the newly formed, not really as new, kasi you were already toying with this idea 2 years ago, headed by, of course, Dr. Nuevo. And of course, I saw most of you as members of this committee, Dr. Chamson, pati ang si Father dati, nawala na sa atin, no? May bago na tayo. And then neuro was with you. Of course, surgery, and then nursing, and then psych. It was a multi-faceted specialty committee. And they already started to draft the guidelines. I think there were a lot of consultations made. We have the input coming from UPPGH, coming from DOH, and many other institutions. This, I don't know if we will call this a subspecialty, no? A specific care. I know you talk about this the whole morning, and I will not agonize you over that again. But the need definitely is there. I think you all agree, right? And difficult as it is, as in any endeavor or program, the toddler stage is always met with challenges. But of course, we never give up. And I would like to read about this saying given again to me by a nun about flexibility, no? I let myself flow with the situation as a master. I am not flustered or stressed by difficulties. I let everything go, passing through me like water through my fingers. Beautiful words about encouraging people na we adjust to the time and we allow things to happen. I was also able to talk. Si Neil, is he here? Neil Blaso. Because we sent Neil and another nurse, nag-immersion sila sa Singapore on palliative nursing care. And doon sa ER pa lang, they already identify patients who will eventually need palliative care. Ganyan na sila ka-advance. No? And then once identified, may specific wards sila, no, or part of the hospital where they can put this kind of patients who will need extra care. Now, sa atin, particularly cardiology, no, definitely it's not just cancer or any other disease, but we have lots of chronic heart failure. What will this end-stage cardiomyopathies, and ischemic cardiomyopathies and the whatever etiology, and then we have these patients coming back and forth to the emergency room. Sometimes they congest our emergency room. They eat a lot of times. Now, if your functions can even overlap, that eventually you can establish linkages in different areas where these patients can go to. That will be a lot of help for these patients. No? Imagine traveling all the way from a far-flung province, tapos pupunta ka dito, and then of the line, uuwi ka na. And then we've seen also the dilemma. I know medyo ano pa ito, debatable pa yan ang where is the cut-off. Now, I heard you debating end of life, but when do you pronounce the person to be that? 'Di ba? May mga heart failure naman tayo na after proper management. Sometimes we even bring them back to functionality. So kung ganon, this kind of patients, catchment area din yan. Whereas we have relegated them as hopeless, meron pa pala. And for those talaga na end of life, so to speak, no? So our values tell us, no, di ba? We stick it out with them up to the last breath. No, hindi tayo kagaya ng US, we leave them to the institutions or home for the aged. Tayo, andyan sa tabi talaga natin up to the last breath. So that phase of life is a very cruel part of life, no? Kaya we also talk to each other. We should really prepare for our own future as well. We should save enough for our own medications because whether we like it or not, we are going to go through that phase of our lives. So, be that as it may, I think it helps a lot. No, I think kayo, ting-tang kayo, you have thought of endless possibilities how to make this phase of life more comfortable, less pain, no, a little more hopeful, and then also even you're treating the family as well. Now it would be great deal to the family. Alam nila may katuwang sila, no, may nagga-guide. Oo, ganyan na yan. Ito yung gagawin, itong ganyan. So that gives hope as well. Or sometimes that's the only thing you can give na to these patients. But that's a big deal for these patients. What else can you give them, right? And with that, of course, the comfort, no? At saka the love and care that you can share. So I know you must be very hungry at this time. So thank you for hopefully we can already implement what you guys have you already written down. And perhaps, as you said, linkages here will be important as well, that we interconnect and communicate with our counterparts out there as well as in the other hospitals. So thank you for attending this workshop.
Thank you very much to all who joined here at the amphitheater and on WebEx. And we invite you to our second symposium that will be announced. And the objective of that second symposium is the implementation on which we'll have to discuss with the nursing services. Yun po yung part 2. And part 3, with those insights from Dr. Manso, expect for a pro-con debate. Okay, yun lang po. And let us all sing the PHC hymn. Lance? Happy anniversary.
May giting na tangi ang lupa ko ay pinig at ibig ng luwalhati ang alay ng puso pag-ibig na dakila ang alay ng puso ay pag-ibig na dakila ang alay ng puso sa lahat ng lahi at bansa. Lahi ako't ibig, may giting na tangi. Ang lupa ko ay pinig at kibib ng luwalhati. Ang alay ng puso, pag-ibig na dakila. Ang alay ng puso ay pag-ibig na dakila. Ang alay ng puso sa lahat ng lahi at bansa.